all translate to start the voice recording. Thank you very much, everyone. Welcome. I'm going to start meeting with this one. Let me, share here, this one. Okay, not this one, this one. Here you see, I hope everyone can see and hear me. And then I will ask the operator to make everyone mute. All right, thank you. Here you see, ladies and gentlemen, this is the figure from Turkey, how COVID-19 is going. Here you can see on the left side, we had almost 1.3 million the positive cases in Turkey from the beginning. No, we tested 1.3 million people in Turkey. Within this group, the 135,000 COVID-19 cases test positive. Until now, almost 3,700, the mortality case in the country. As you know, Turkey is 82 million population. Today, this is, if you see my slides, my miles on the screen, and then you see this is today's mortality is 48. This is going down. It used to be 125. Now it's going down. And then you see this figure. We are doing not bad from the beginning. We've been able to control the cases in the country. There are three important points on this success story. Number one, the government has taken a strict measures in the country to close down, then also banned all people who is under 20 and over 65. From the beginning, the over 65 and later on under 20 years of age people are locked down in the house. And then all public places, restaurants, bars, and the malls are closed. And then now we've done almost 1.3 million tests until today. Almost, we are trying to make more. But if you come to this figure, you will see the run on the left side. How is the situation, throughout the world? It's getting, sometimes worse, sometimes better. In which country you are in. But let's say this one is Spain. It's going to come up, and then the thing is, for me now, not few months later, it's going away. We will get this difficulty for months, maybe more than 1 year. Therefore, our target is today, our topic is today is pregnant women. What should we do for our pregnant women? We will discuss this point today. And then there are many papers, editorial and short review, then even, sometime guidelines. As an example here, you see, there are some sentences here, as you can see, seems to be not so severe as SARS and MERS in COVID-19, but in terms of fetus, we don't have very much information in the scientific outcome. Therefore, just to let you know, the board of the World Association of Perinatal Medicine decided to work on this matter. And then what decided was to create a study group, is a registry for COVID-19 in pregnancy. As you can see here, this is the website of WAPM. Then this is until now the list of centers who are in this study group. This is the open study. And then the Italian friend helped me very much on this registry study. And then later on, the board decided to make a webinar on COVID-19 in pregnancy to discuss what we can do, what is the latest information COVID-19 in pregnancy, and also what is our preliminary results from our registered study. We already submitted the paper to journal that I will discuss in a minute. Here you can see this is the program of today. The first speaker is Awesome, and after that, Giuseppe Rizzo, Amos Gurnabon, Frank Chevenak, Ignacio Herraiz from Spain, Gabriela Saccone, Olu Shapi, and myself. And then the first part, 4 speakers. Then after that, we will make a question and answers. On your Zoom screen, you will see Q&A button. At the time of question and answer, or even before, if you like to raise a question, put your question there, and then which we can see your question there, and then I will direct your question to speakers and discussers in the panel. Then after that, in the second part, we will cover those topics. At the end of the session, then you will see another question and answers at the end of session part. We will enjoy, I hope, today very much. Now, I want to, give the microphone to Asim Kuryak and to share what, he thinks and what he's going to give his thoughts today. Asim, would you please share your screen and presentation? Thank you and welcome.
Thank you, Jihad, and thank you again for this lovely initiative, putting us all together in this terrible time. I will start with something from my country, Croatia, and not to advertise its natural beauty, but the most beautiful city, Dubrovnik. Many of you know this city because it's a birthplace of learned societies like Donald School, like Fetus, and so on. I'm showing this city because at the time of pandemia, this city told us what the leaders of Dubrovnik, it used to be city-state, did 600 years ago. First quarantine in the world, in Europe, was born in Dubrovnik. Anyone visiting this city had to stay for 40 days. That's why named quarantine, to solve the problem. So at the moment, my friends, absolutely the best treatment of coronavirus is quarantine. So we have to confess that this invisible devil affected the life of every single human being on the planet. But the numbers, real numbers quoted now, are really much higher because due to the lack of test capacity and due to the underestimation in the reporting. There is something good. Although this dangerous virus has really very fair one role, choosing not only poor, homeless, old people, people with chronic diseases, but also prime ministers, crown princes, celebrities, absolutely in the equal way. But one of the most vulnerable part of population are women, and in particular, pregnant ones. But unfortunately, data, serious data, extensive data, proved data, scientific data on the real incidence of coronavirus in pregnancy are not available or are from middle income and low income countries. There is very different system of health protection. The same goes to Ebola. Legitimately, I found till the end of April, 18 articles reporting about 108 pregnancies between December 8, 2019 and April 1. This is very interesting, and as you can see, not enough. One neonatal death is reported, 6 admissions to the intensive care unit, and the main cause of dying are premature birth and cesarean delivery complications. And while most of the reported cases focused on the maternal outcomes and possible vertical transmission, less attention has been paid to fetus as a patient and newborn. And I must say, as the editor of some journals and some experience, as many of you do have experience in editing journals, most of the published paper would be completely unacceptable for serious science in any other circumstances. So we are dealing with something which is pushed to us, pandemic conditions. So what are my criticism? Papers are published fast, without proper peer review processes, using small or often insufficiently representative samples, numerous imperfections in the research study, and all of these factors resulted in a flood of superficial research, and all in desire to get answers as fast as possible. Unfortunately, my friends, rush and wrong answers can cause greater damage than an accurate but slow one. It is also realistic to expect that whole series of daily reports on various scientific research results, which will in a week or two turn out to be wrong or unfounded. I can quote you several examples from this country. One of our doctors working in Germany published 3 days ago sensational news that he discovered cause and structure and genome of coronavirus. I called Merz asking him, did German newspapers, where it was originated at the University of Frankfurt, publish anything about it? He said that he's following, nothing happened. So that was self-promotion, and this has to be prevented. Fortunately, we scientists will soon recognize what are true scientifically proven facts, but not journalists. Journalists will pick up sensation because it goes on the front page, and we should be very, very careful before giving them that type of information, because more than half of the world population is under lockdown conditions, at least by early April. One problem appeared, violence against women, for example, in the place when it started in China, have 3 times increased violence in the April as compared with the April 1 year ago. Ladies and gentlemen, I do require as much as possible scientific criteria, because in science there is no good and bad work. From the Platon time, science is place of the most knowledgeable people, highly influential, and they do advise, you know, what to do in this difficult situation. We have International Academy of Perinatal Medicine, which is now 12 years old, and that academy had remarkable past, and I do believe brilliant future. And future depends on the activity of each of us. I'm glad, Jihad, that you invited 5 members of Academy to join your group, led by Eric Salling, who support all of our actions. And I am sure that within Academy, several projects are started, which will show again that intellectual power of Academy is promising one in order to solve this global pandemic. Those are pioneers. You can see Frank Chervenek, Carrera, you know, and some of us. But the man who recently joined us, also member of Academy, Milan Stanojevic, is now leading ad hoc committee of World Association and Academy to study something which is catastrophe. 500,000 pregnant women are dying, my friends, without any changes during the last 10 years. We created new committee, very active committee, how to train the teachers to solve this horrible problem, which is tragedy for developing countries and shame for developed world. So academy has responsibility and privilege to conduct scientific research on this pandemia. And these present members of academy are involved in several studies, and they publish first reports in Journal of Perinatal Medicine, our official journal, and will continue to work, and we will have Marrakesh, I hope by the end of this year, annual meeting where we will discuss extensively contribution of academy and what academy can do. We will be deep in analysis what science in perinatal medicine did assess already and what it recommended to perinatal world. Because academy is the best we have as far as science is concerned in perinatal world. And we are also lucky to have Journal of Perinatal Medicine and Academic Corner. Next week, Academic Corner will be distributed to all of you. You will see 7 contributions from members of Academy. This is our journal and my own editorial coming out in 2 to 3 days on pandemic coronavirus issue and how do we respond. Ladies and gentlemen, principle of any academy, and particularly the only academy, scientific academy in perinatal world in this terrible situation, shouldn't be only any information is better than none. Information should be feasible, usable, implementable, and proven according to the best scientific principles. It may that the research of the members of academy will not be the first to be published, but we certainly aim that the scientific evidence published by academy is fast, reliable, and implementable. I'm sure results of our webinar study will be the same. So this is open place for permanent follow-up what will happen at the time of adaptation after coronavirus. But ladies and gentlemen, as far as scientific interest, organizational interest, professional interest in this pandemic affecting half of the world is concerned, this is not the end. This is not even the beginning of the end. This is the end of the beginning. Jihad, good luck to prepare October meeting. Thank you.
Awesome. Thank you very much. That was nice part. Then we would like to make this slide off, and very good. And then now I will ask to Giuseppe Rizzo to give your presentation and to share his knowledge. He's done a nice study on COVID-19. And then just start off. Giuseppe, thank you, welcome.
Thank you to you, Chiat. Thank you to all the World Association of Perinatal Medicine to allow me to participate to this important and first webinar. First of all, I would like to share the honor and the privilege of this presentation with my co-workers, Flavia Di Stefano, who is the chief of the psychological team that assists our patient in the maternal fetal medicine, and Ilenia Mappa, she's a gynecologist who have the idea to perform to study and follow up the most of the step of the study. So it's not difficult to understand why a pandemic like COVID may affect the anxiety of depression of the population. And as we've heard before, this is particularly important for pregnant women. What we know is very little, as Azim told before, and is mainly derived from previous pandemics, which at least in Europe are probably less serious and less seen for the population. The biggest one was probably between 29 and 2010, when we have the swine flu. And what we know that looking simply at the anxiety, when there is the announcing of the pandemic by the World Association of Health, which happened the 29th of April, you can see that there is in the general population a sharp rise in the level of anxiety that reach the maximum after 2 days. After the 2 days, there is a progressive decrease on the anxiety level. This is something that was similar in for COVID-19, and this is a first study from China, again on the general population, in which they send to all the population by internet a questionnaire, which was sent the 31st of January, which is an important day because it was the day in which was declared the pandemic. And this questionnaire self-reported a series of items which are reported, like frequency of anxiety, depression, specific phobia, and all the other things that you can easily read. There is a score ranging from 0 to 100, and this author classify ansia in 3 levels. Below 28 was normal, between 28 and 51 was mild to moderate, and above 24 was considered as severe. And you can see how the 31 of January is immediately after the declaration of the World Health Association organization to the beginning of the pandemia. And this is the study. They developed this COVID distress index. They sent to more than 5,000 patients. And you can see how in this general population, about 35% of the population have mild to severe level of anxiety. What was of interest when we analyze the person which are more likely to have anxiety who are female and are people in aging between 18 and 30 years old, which are the same period in which usually women are in pregnancy. A similar study was again performed in China. And here in the same 3 days after the beginning of the pandemic, it was sent a questionnaire in which 2 different indexes were evaluated. One on assessing the anxiety, the other one assessing the depression. The study was more limited in number. They reached more than 1,000 people, male. And again, they found that the severity of the modification of the behavior is very high. And in this population, they reach approximately 70%. Again, when we try to subgroup the data of these authors, it's clear that female and people ranging between 20 and 30 years, which are the typical period in which women are pregnant, are the more characteristic that may increase the level of anxiety. So what we don't know if this distress in psychological problem and in behavior problem that are well described in the general population also fits for pregnant women, and if we can apply the same model of the general population to pregnant women. What we know that independently from the problem of the pandemic, anxiety disorders during pregnancy are frequent, and literature say that they are between the 20 and 55%. So approximately 1/4 of our women suffer of these disorders. And of course, they are serious problems as reported in this recent review, in which very well express how this problem of anxiety and behavior can have a severe effect also on the fetus. On this basis, we try to design this study, which is very simple. We selected a group of patients. We attended our antenatal cleaning in the previous weeks, and which ultrasound and clinical examination results absolutely reassuring. So our women that theoretically should be happy how their pregnancy is going. We sent to them an online semi-structured questionnaire, and we delivered the name of March. The name of March is really important in Italy because the day in which the government improvisely decided for the lockdown. So all the people know that the day after cannot no more go out. And we sent this questionnaire and we analyzed the data. This questionnaire is divided in two parts. Part A, which is mainly studied to evaluate maternal characteristic and maternal fear and concern, and part B, in which two indexes that I will explain you later analyze the level of anxiety. The level of anxiety are evaluated with this index, which is called State Trait Anxiety Inventory. It consists of 40 different items. For each item, women have the possibility to respond with a scale of 4 levels. And if the total of the points was above of equal to 40, this is considered abnormal according to the international literature. And with this test, it is possible to assess two different types of anxiety. One is called state T, which is the trait anxiety. In other words, the anxiety that the patient have independently for the pandemic. And the second one is state S, which is the anxiety which is induced by a situation, in our case, pandemia. We sent 200 questionnaires on the 9th of March. We have a very high level of response. 89% of women respond within 2 days, which represent, as I showed you before by the experience with the previous pandemics, the maximum period in which there is an anxiety response for an individual. You can see our population is a very homogeneous population. Most of the women are Caucasian. 1/2 was Paros, 1/2 was nulliparous. There is a medium high level of education. Most of the patients are conceived spontaneously. Almost all the patients are married or living with a stable pattern, and most of the patients have a job. So theoretically, it's a population of with a well-stayed women, so we cannot expect a big level of anxiety for social or economical problem. Indeed, we have some surprise by analyzing our data. First was how the patient have the information about the problem of the COVID-19. And as you can see about, in most of the case, patients have information from the television or newspaper. Most of them have by internet and web connection, and only 7% receive information by doctor, a specialized number of people that have to have care of the pregnancy. So most of the information are self-made. Which are the major concern of our population? The major concern, contrary to what we believe, that the patients are afraid to not be able to have regular antenatal visit during the period. Also, if this patient have been reassured a few weeks before that all is fine. The second first was to have contacted by the virus without knowing. And third, to have not receiving sufficient information on COVID-19, and so not to be able to be aware correctly. When we look at the specific fear about the baby, you can see that the highest fear of the patient is to have a problem in the growth of the baby, despite there are no evidence in literature that the virus can generate a defect on the fetal growth. and they have again a prevalence of fears about the baby can have structural anomaly. Again, there are no evidence in literature that the virus can change any kind of fetal structural anomaly, and probably they are correctly worried about the possibility of preterm birth, which is the only things that up to now may be related to the presence of COVID-19 infection. When we look at the level of the this index about anxiety, you can see how the level of the STAI score are higher than from the baseline, indicating that the pandemic of COVID increased the level of anxiety of our women. Of interest, when we look at the individual point and we put a line on 40, but as I told you is the cutoff to define normal and abnormal, the percentage of women that reached an abnormal level of anxiety was significantly higher after pandemic than when they are before. And you can see here the number. In our general population, 40% of women have an index of ansia above the norm, which is consistent with the previous literature, but this index double with the presence of pandemic and reaching the 70% of the population. When we try to look correlation between the level of anxiety reached by the pandemic, you can see that there is a significant relationship between the basal level of anxiety and the reached after pandemic, suggesting that women that starts with a higher level of anxiety before pandemic have a further increase, a more evident increase in their anxiety. Then when you look at other characteristic parameters, we found that the women that an higher level of education have a statistically significant higher prevalence of abnormal values of induced by the pandemic rather than the women with a lower education. No, we are unable to find any significant effect for the other variable tested, although we acknowledge that our population is always uniform and probably using a more heterogeneous population after different can be found. So the conclusion of our studies is that the outbreak of COVID-19 and the subsequent national lockdown induced in a significant increase in maternal anxiety, and we take as a score the STAI, there is a doubling of this level. And in our population, the increase in anxiety level is related mainly to the pre-existing level of anxiety before the pandemic. Higher the patient are anxious, more higher is the increase. And from the maternal education status, higher is the educational level, higher the level of anxiety. So what we have learned, but is a small experience, but we would like to share with you, it is possible to send a questionnaire to your population. You can therefore identify women which are at risk of anxiety, and in such women, we can start an early psychological intervention that may be useful for the mother and probably of the fetus. And the most important thing is that you can do everything online, which is very useful in this period. I thank you very much to all of you for your attention.
Thank you very much, Giuseppe. That was very nice and an excellent study. Thank you for sharing with us. And then, at that point, we will not start the discussion, and we will start discussion at the end of the session. But let me introduce Professor Amos Grunebaum from New York. He has collected lots of information and experience in New York, and then let's hear Amos about COVID-19 in pregnancy. Welcome, Amos. Can you share your presentation with us, please? We cannot hear. We cannot hear you now. Yes. Ne oldu bu? Şeye gitti. Amos, are you all right? Amos, we cannot hear you. Onu şey yapsana. Unuttum. We cannot hear you. Amos, we cannot hear you. Yeah? Do you hear us, Amos? All right. I can. Okay. Amos, I cannot hear you. Please. Amos, check your interpretation, button on your screen, because I cannot hear you. Frank, do you hear Amos, Frank?
No, I do not hear Amos.
Yeah. No one cannot hear you, Amos. Please, the mic is, yeah.
I see Amos, but I cannot hear Amos.
All right, Amos, let's do on that way. Then we can switch to Frank presentation, and then at that time we can fix Amos' voice problem. Yeah, and then niye yapamıyorum şeyini? Amos'u. Okay, Frank, would you like to share your presentation with us, please?
Okay.
Yeah, go ahead.
Frank, we can hear you.
All
Good.
right.
And you can see me?
Welcome.
Yes. And
Yes,
hear.
both are okay, yes.
First, can I say thank you, Shahad, to you? We've always known you're a brilliant organizer. Special thank you to you for bringing us all together so at least we can see each other. And it's a pleasure, Azim, to see you again. And to see you're healthy and
The same to you, Frank.
Pleasure. First, I want to say this presentation is a collaborative effort, not just from Larry and Amos, but so many people here at Lenox Hill and throughout my whole system at Northwell and Zucker School of Medicine. I assure you there are no conflicts. And I just want to address one question that I've never had to address before. Is it consistent with integrity to compromise maternal mortality? And you'll see what I'm going to address in my presentation. I want to start off by saying how quickly this evolved. The month of March, just 2 months ago, started off as a very, very happy month. Here you can see Azim and me and our hosts, Yaron and Lara, in Kiev. We had just had a very, very successful Ian Donald meeting, and we had just come off the heels of another successful Ian Donald meeting in Jeddah. And I was very happy as I took the plane back to New York City, very, very happy. Our global efforts were totally in stride. We were all ready for our meeting in Marrakesh. In fact, we were going to have an ethics meeting in Zagreb that Lara was coordinating. Everything was beautiful. Little did I know that when I arrived back to New York City in March, the shock that awaited me and the ugly tragedy of the COVID-19 pandemic that everyone on this teleconference is aware of. New York City was hit especially hard. The city that never sleeps went into hibernation. Please, all our restaurants were closed. Even the barber shop was closed. I couldn't get a haircut. So I just want to show one slide to put this into perspective. There's a beautiful church across the street from my hospital. And usually on Sunday, it's packed. There are no masses. They open it for 1 hour and no one went to the church. It's empty. It's empty. And I think this one picture typifies what happened in New York City when it was at its worst moment. An empty church where usually it is filled on Sunday. This hit my department especially hard. I lost one of my older doctors, a Dr. Buterman, a Dutch-American physician. You know, New York City is a city of immigrants. One of my younger doctors, some of you may know him, he's a rising star in reproductive medicine, Tomer Singer. Fortunately, he come better. He had a near-death experience. Here he is, he gave an interview. He came so close to dying, and he still has trauma. Giuseppe, you gave a beautiful presentation about anxiety. He is still traumatized when the people in the intensive care unit asked him, should he be do not resuscitate? Here is a young man in his 40s with 2 young children. Thank God he recovered. Now, as you know, those of you who know me know I love history. There was a time in the Revolutionary War, the American War for Independence, where there was a very dark moment, where the British had kicked George Washington, his troops out of New York City. Thomas Paine said immortal words, "These are the times that try men's soul." And I can tell you, those of us in New York City, myself as a chairman, our souls were tried. And I think many of you share these sentiments. These are the times that try men's and women's soul. Outside my office window is, those of you who don't know my hospital, it's located in one of the best locations in New York City, is this. This is not a truck. It's a refrigerated morgue. So many people were dying in my hospital. The funeral homes couldn't accommodate them. And as a result, there had to be a refrigerated morgue. It's still outside my hospital that is in place. Before I tell you the crisis that we had to face, I'll go very quickly. I'm a strong believer that professionalism dominates all that we do. John Gregory and Thomas Percival, 2 great physician philosophers, advocated that we all should remain scientifically, ethically, and clinical competent, put the patient's interests first. I love this image from the Royal College. The scientific excellence at the time, the Chamberlain forceps, melded with the compassion of the midwife. Then and now, this is what we embodied as obstetricians. Now, what is professional integrity? We have to be evidence-based. Professor Koryak said it so beautifully, as he always does. And I'm ashamed, as I know Amos is ashamed, as he'll describe labor, when our president, one of the most powerful people in the world, espouses day after day scientific nonsense. I won't dignify this with any details when he goes against his scientific advisors. I just want to echo what Azam said, and I know we all believe him. Even if we don't say it quickly, we must have scientifically correct solutions to the issues that arise. Now, professional integrity is essential. No uncontrolled variation. We need clinical trials. I'm going to stay quickly so that we stay on time. Now, we need to do the best we can. I can tell you, when this first broke out, we didn't have enough protective equipment, and we didn't have enough testing. Even to this day in our system, we still don't have all the testing that we need. And I can tell you, I've been involved in endless teleconferences, several times a day, every day. I'm still involved. Fortunately, the pace has slowed a little bit, to do the best we can, with incomplete evidence. Often we don't have best studies to guide us. As Azam said, we only have very little data to guide us, but we use our best judgment, and this is where humility is important. We all need to work together, and I'm delighted to work in a place where this is the case. What does this mean? Strict adherence to criteria for testing, strict clinical criteria for admission, to critical care admission, and to critical care management. One of the roles I play here at Lenox Hill is that I'm chair of our ethics committee. And there have been endless meetings about triage, something that I thank God we never had to implement. What does that mean? Who we would turn away from the hospital, who we would send out of the intensive care unit. And literally we were reaching a crisis point at our hospital. And this sets up what I want to emphasize, what tried my soul, is that the decision I had to face as chairman was to relocate our entire obstetric service. We have a busy obstetric service here. I built it up the past 2 years, about 4,500 deliveries, to an alternate site about a mile away. And in order to do this, we had 4 days to do this, 4 days to do this. And why would I even think about such a thing? Is because 80% of our hospital here at Lenox Hill was filled up with COVID admissions, and our ICUs were overburgeoning. It was a disaster here at Lenox Hill. It was a true crisis. I think many of you who follow the news see what was going on. It was to change this and to send our patients a mile away would jeopardize patient care. I don't have to tell any of you, as leaders in obstetrics, this would have been a problem. I was so grateful to work with the team. We had well over 100 people, not just doctors, nurses, all sorts of people who were going to reconfigure Manhattan Iron Here Hospital a mile away to accomplish this as best we can. I knew that there would be an increased risk of maternal mortality and morbidity. However, failure to expand capacity would have resulted in immediate deaths from COVID-19 because literally we'd have to turn patients away. Now, in a public health emergency, professional integrity has to be applied to the entire population of patients, not just obstetric patients. And this justifies prioritizing preventing a large number of predictable deaths over a very small number, if any, of possible maternal deaths. And the concept that I want to introduce, something I've never had to face in all my years, and something we all have to be aware of, is frameshifting. Population-based, beneficence-based, deliberative clinical judgment differs from individual patient-based, beneficence-based, deliberative clinical judgment, which is something I've lived by and have taught in my international and national lectures throughout the years. The initial concern about moving obstetrical services was individual patient-based. However, in a public health emergency, we have to frame shift. In this context, by moving obstetrics off-site, deliberate clinical judgment focuses on reduction of mortality as much as possible for the general population. So if I can go back to the question that I posed initially, is it consistent with professional integrity to do this? I would suggest yes. In a public health emergency, it's crucial to distinguish the individual patient from a public health emergency. And we have to go beyond individual patient-based to our obligations to the population at large. In a public health emergency, it would be appropriate to move this off-site. Now, the challenges of obstetricians certainly include the stress. This echoes what Giuseppe said just a few moments ago, to meet each individual's needs. And believe me, I and my team of obstetricians went through tremendous stress at this time. We need to expand the concept of the professional virtue of integrity to include the population of patients at large, not normally served by obstetricians. And very briefly, so I stay on time, Shahat, one other concept I want to introduce, and it was Amos Grunbaum who brought this to my attention, is the concept of ring fencing. We as leaders in obstetrics need to ring fence or defend everyone to protect our obstetric services. True that this COVID-19 pandemic affects the older people much more, but we need to protect services for obstetric patients. There's so much more I could say, but let me close on a very positive note. Very slowly here in New York City, we're winning the battle. As I said, at the height of this emergency, we were up to 80% of our hospital was COVID emergency. We're going down precipitously. We're now down to about 35% of our hospital, and it's going down. The other good news, there's been a consciousness raising here that doctors, nurses, and healthcare providers are important. Please, food has been delivered to our hospital, and we never are hungry. And people realize that doctors, nurses, healthcare providers are so important. And this is so, so good. And I hope this is going on throughout the world. Shahat and everyone throughout the world, there's so much more I could say, but let me stay on time. I congratulate you again, and to all my friends throughout the world. As our souls are tried, we are an international community, and this gives us strength as we fight our battles together. Thank you so much.
Frank, thank you very much for your thoughts and your experience you've been sharing with us. That was very important message to everyone, I believe. Now it's time for Amos. Amos,
can you hear me now?
Now we can hear you very well. Then please start up. Thank you. Welcome.
So I'm going to talk about the New York experience. And as you know, many people say New York is the center of the world, and we are again the center of the world. These are the numbers that I just downloaded. On the left side today, on the right side yesterday. And you can see how rapidly the numbers of cases are increasing. 100 cases a day. These are the global data on the left side and on the right side. And on the left side, as you can see, New York has 26,000 deaths as of today, which is the largest number of any place in the world. Our president wanted to make America first, and finally he achieved it. We are first in corona death, and New York is first among the United States. In New York, we have a governor, and I don't know if you heard about him. His name is Andrew Cuomo, and he and the president of our health network, the hospital we work at, Frank and I, work close together to make sure that this is being addressed. And every day at 11:30, the governor speaks, and most New Yorkers listen to when he speaks. It's a very interesting, important part of our New York life these days. We are clearly the epicenter, not just in the United States, but also in the world. This is a hospital, a tent hospital in the middle of Central Park, which was built and now disassembled. It was built for a month during the height of the crisis. It shows you that we needed additional beds and we just did not have them. Who would ever imagine that in New York City, in Central Park, you would have a tent hospital city built? Fortunately, our cases are going down. You can see them slowly going down. The height was about a month ago, and now the cases are going down. We have been on isolation, on quarantine for the last 7 weeks. In New York, cases are going down, but not in the United States. In the United States, cases are continuing to go up. And these are individual states within the United States. There is right now a lot of political infighting going on in the United States, whether you should reopen or not. And these are some of the states that are starting to reopen, and they're starting to reopen even though they were told that they should only reopen everything when cases are going down for 14 days. And despite this, cases continue to go up and they continue to reopen. So they're making a calculated risk, calculated numbers that patients are going to die even though they're reopening. The crisis, the coronavirus crisis in New York has created a lot of opportunities. And this was one of the first papers from our hospitals presenting 5,700 patients and providing characteristics. I would recommend that when if you're interested, it's in the Journal of the American Medical Association from our hospital. 5,700 patients admitted in 1 month at our hospital. We also published on our pregnant patients. This is a paper published by Frank and myself, pregnant versus non-pregnant corona cases, just published in the American Journal of OBGYN. And as you can see, during a 4-week period from March 2nd to 8th, and the last one, March, this was the end of March, the numbers significantly increased. Overall, and also pregnant patients went up 20 times. So this was a very, very difficult time, which we now documented in this publication. This is a publication from one of our other hospitals in New York, which showed that pregnant women, most cases were mild cases, and few of them were critical cases, less than 5% critical cases. And we also published on this, our team, in the American Journal, was just accepted last Monday. And we showed that pregnant patients and non-pregnant patients had about the same number of intensive care admissions. So contrary to many other virus infections, in pregnancy, at least in our present experiences, our pregnant patients are not more likely to be admitted to the intensive care unit. It's just published in the American Journal of OBGYN for everybody to read. Frank published a paper in the Journal of Perinatal Medicine. He talked about this, expanding the concept of the professional integrity of obstetrics during public health emergency. And we initially, when we had the discussion, we lost. We were told we had to move. We didn't want to move, but we decided it's the right thing to do for the overall, for the hospital. And Frank talked about ring fencing. It has its origin in to build farm animals. And what we argued for is that women and children should be put first in this crisis, because we were told it's not so important. There is a lot of chaos has been going on in our hospitals with pregnant women who wanted to have their babies, who were told they didn't have, they were not allowed to have a partner in the room, on and on. So it was a very painful decision. And I didn't even go to an increased interest in patients supposedly wanting to have home birth in New York and in the United States. There is daily an update on information for COVID virus and pregnancy. Here are just some of the more reliable data. I recommend, if you're interested, to go to them. Society of Maternal Fetal Medicine, American College of OBGYN, Centers for Disease Control, and the Royal College of OBGYN all have websites that journals cannot really be as fast as those websites updating the information. 7 weeks ago, everything in New York was closed. For those of you who have been to New York, this is Times Square, nobody there. Wall Street is closed. It's all done electronically. Everything is empty. And then last weekend, what happened? We suddenly had nice weather. People came out, and this is a picture from last weekend in New York City. And a lot of people have distributed those pictures, how upsetting they are, that despite people being told to be quarantined and stay at home, people went out and were close together. New York is what it is, New York, and hopefully we'll be back. Might take a long time. And for those of you who like some music, at the hospital, every time somebody gets discharged with COVID virus, they play a song. And this is the new New York song. It's from Alicia Keys, New York, New York. And one reason the microphone was off before is because I was trying to play it for you for about a minute. And can you hear this?
We do.
Can you hear it?
Yes, we do hear.
Always loud, there was sirens all around in the streets of me. I can make it here, I can make it anywhere, that's what they say.
So
Good.
I'll just give you an example of what we're trying to do to uplift our spirit in New York, despite everything else. I live in the middle of New York, and I hear every hour, several times, ambulances going by. It was much worse a month ago. So hopefully we're going to get there. It will take a long time. And thank you.
Thank you, Amos. That was nice presentation. We enjoyed very much. Now it's time for question and answers. I'm asking all participants to put your questions into Q&A box, not chat box, because we will be able to follow your question in that box, Q&A box. Oh, right. There is one comment from Andrea Lara. I don't agree that women are an element of risk since the majority are men. That is a comment in different way. And then Indonesia, Ina Damayanti asked that Indonesia started convalescent plasma trial. Is it safe for pregnant women diagnosed with COVID? Does anybody have any answer? Yes, Amos, go on.
Yes. So I think, can you hear me?
Yes, we do.
At the present time, we don't know about it. We have not enough information, at least at our place with huge numbers of pregnant women, whether that works or not. It has been used. There's no contraindication, but we don't have enough patients to say it will work or doesn't work.
Okay, thank you very much, Amos. That's nice. And then also, we made unmute for every participants. Just pay attention on this one. If someone would like to speak, just carry on. There is another question. What do you think about hydroxychloroquine use or not use in pregnancy? Does anybody want to make any comment on this? Frank?
On what was this, hydrochloroquine?
Yes.
Yeah.
Pregnancy. Use in pregnancy.
It's not.
Go ahead, Thomas, go ahead.
It's not contraindicated, and we've been using it, but the issue is that at the present time, pregnant or not pregnant, there's no information that it really works. So we don't really recommend it, but we know that a lot of people are using it. But there's no randomized control prospective trial showing it does work.
Very good. There is another question from Anna Daneva. Oh, excellent meeting. I have questions about the use of thrombophylaxis in pregnancy positive with COVID-19. Giuseppe, do you have any comment on this?
Yes. In Italy is something that is really very much emphasized, because not for the women we have fortunately very cases with severe complication, but on the general population there are autopsy studies showing that most of the people that die have indeed micropulmonary embolism. And so at the best of my knowledge, now in Italy, all the centers are using routinely anticoagulant therapy on patient.
Super, super. This is excellent.
One more question. Rodrigo. Yeah,
Amos. Yes.
I think Rodrigo asked a question. He asked me if women are allowed to have somebody accompany them.
Rodrigo, would you like to repeat your question, please?
Yes.
Yeah, let me introduce Rodrigo Ayala. Rodrigo Ayala is the General Secretary of the World Association of Perinatal Medicine from Mexico. Thank you again, Rodrigo, for your contribution. Go on.
Thank you. It's a simple question. We've been having big issues here in Mexico because there's no specific alignments or rules of how to conduct the deliveries. So each institution is implementing their own rules. And based on this, I just wanted to know what your experiences in what your experiences over in the United States with this accompanied delivery. Many women here are demanding it. They just don't want to be alone. But sometimes the facilities are not the adequate ones to have a partner in there, and it can actually pose a threat because we don't know what conditions the husband or whomever is going in with a woman. And although we might have all the necessary precautions with the women who's our patient, we do not have the knowledge on how the husband is what conditions he's in, or does he bring any studies about. Now, this I'm talking about the various small clinics that we have a large number of small clinics in Mexico. As government hospitals, they're very tacit, they're very strict, and they will not allow anybody to go in. But the huge concern is basically with the small clinics. As for you, the people who do not know what the situation is in Mexico, right now the number that I just consulted it is we have 31,522 confirmed cases of COVID. Although in the recent dates, it's been highly questioned that these numbers are that accurate. So I just wanted to know what the Amos and Frank are experiencing in their scenario in New York City. Are you allowing these women to be accompanied?
Can you speak?
Yes, please. Yes, go on.
It's very straightforward. The governor of New York, Mario Cuomo, had a task force. I can send you their conclusions. It's online. We have to have the woman allowed to have one partner to accompany her, and we have to allow her to bring a doula. So 2 people are now allowed. We cannot outlaw people not coming in. So no hospital in New York is allowed to tell a woman to not bring the husband or doula. And we can obviously discuss this extensively. There's a lot of discussions about this, but the bottom line is that we have no choice as a hospital because we have been told we have to allow it. Having said that, if you really look at it from a support point of view, women are supported by doulas and by husbands, and oftentimes there are not enough nurses around. So it is not a bad idea for a woman to have somebody with her, who is properly gowned and has properly PPE, personal protective equipment. So we allow it in all of our hospitals.
Excellent. All right, awesome. Carry on, please. Yes. Awesome. Okay, carry on, Awesome. Now we're here.
All right. A question to all who already spoke. What about antenatal management with corona? Does it alter our usual procedure? Is preterm labor the main and complication of cesarean section, because most of the deliveries happened by cesarean section, the main problem for us? Do we do prevention of respiratory distress, antiphospholipid? Do we perform usual measures, or nobody has this data? How about antenatal care of pregnant women with corona? Interestingly enough, in my country, 4 million and a half inhabitants. There is no one single pregnant woman with corona.
Awesome, thank you very much. There will be another presentation in the second session. Then we can discuss your question. This is really important question to be answered. That is very nice. Now, just carry on to another question, and then if we miss some question and answers later on, then we can complete at the end of the session. Krishna Pillai Guruparan is asking about the pregnancy's protection against COVID. Giuseppe, do you have any comment on this?
The protection are the same that in general population. So avoid all that is not strictly necessary to form to community. Just to give a short reply to Asim question. We do not interrupt at all the antenatal care. We take a series of norms to try to limit the contact with the patient, but we are still working routinely with antenatal care. And this is not just the experience of my unit, but all the centers in Italy are working in this way.
Giuseppe, isn't it pregnancy, biological protection of corona? Because the incidence among pregnant women is much less than in normal population.
That's true, absolutely. Also,
fortunately,
if you look at the data that are published, the same meta-analysis report the same case, and the number are very, very limited.
All right.
You're lucky.
Yeah, this is excellent. There are many questions on the box. Actually, you know, the most of them are related to the second part. I leave it to, you know, discussion time of the second session. And then in that time, for the sake of time, let me introduce you Ignacio Herraiz from Spain. And he's going to talk about universal screening in women admitted to delivery. And then most of the questions will be answered after this talk, I believe. Ignacio, carry on. Thank you for joining us. Welcome.
Thank you very much. Thank you, Professor Sen, and I would also thank the World Association of Perinatal Medicine for giving me this opportunity to participate in this webinar. And maybe I will try to convey to you some of the intense and also dramatic experience that we have had in Madrid with this pandemic of the COVID-19. And I also want to say that I'm honored to be able to represent to my colleagues the 12 de Octubre Hospital in Madrid in Spain, who have done during these weeks an amazing job. And I can just say that I'm proud of all of them. And I just want to have memory for two of our colleagues, Encarna and Rosa, who unfortunately passed away recently due to COVID-19, and I guess rest in peace. I want to start just with a small, a brief summarize what is the situation in Spain, as you can see here in this slide. And the thing is that probably the outbreak was out of control, probably at the beginning of March, and the lockdown was ordered, was not ordered until 14th of March. And this is probably, and unfortunately, why we have became one of the reasons why we have became the country with most cases diagnosed by PCR in Europe, and in the third place in Europe in deaths. We have 26,000 deaths, more than 26,000, and more than 8,000 here in Madrid. And as you can see, the lockdown coincides with the peak of symptoms, of people with symptoms, but the peak of the diagnosis and the peak of hospitalization is 1 week later. Maybe it is due to the fact that not all patients, not mild cases, were diagnosed. They were said to stay at home. And I want you to remember these 2 points: the peak here of diagnosis, the peak of hospitalization at the end of March. We saw that it was in Europe, for example, it was in early April. We had it at the end of March. And the restricted use of diagnostic tests, since they are important for what I will explain later. I also have to say that our government has succeeded in decreasing the curve by a very strict and long confinement. Then also the society has respected it. So now the curve is going down quite fast, and we face with some optimism what could happen from now. So remember, end of March, and this is my hospital, Hospital of Octubre. It's in the southwest of Madrid, maybe one of the areas most affected by COVID. It's the largest hospital there, and we have, there's another large hospital in the north and another in the center, but we are the largest in the south, with, you can see, more than 1,300 beds. And during the peak of the pandemic, 1,000 beds were occupied by patients affected by COVID. We attended 4,000 deliveries a year, and these are our numbers that you can see here. And these are our results during the period of the highest period of the pandemic, between the 1st of March and the 2nd of May. 550 57 deliveries were attended during this period. And in 29 cases, 5% more or less, we had to attend deliveries of cases of COVID-19. 2 of them were not confirmed by PCR, but they were highly suspected by clinical features. And of them, half of them were diagnosed before delivery, and of them, again, half of them, more or less, were already negative at the time of delivery. The other half were diagnosed at delivery, and only 1 of them was asymptomatic at delivery. Overall, 21, the 3.8% were active COVID-19 deliveries at the time of attending delivery. And here you can see our results. They are coincident with what has been reported. Unaffected cases, we couldn't see any change. The results are similar to what we usually see in our hospital. Regarding the rate of cesarean sections or other parameters. And also, and interestingly, those COVID cases that were not active, were negative and asymptomatic at the time of delivery, also had normal features with low rates of cesarean section. And those with active COVID at the time of delivery were those that had the higher rates of cesarean section and also prematurity in 4 cases caused for and iatrogenic delivery for worsening of the respiratory status of those women. And well, as I said, and it's also been said, this concept of ring fence the maternities during the COVID-19 crisis. It's clear that while 80% of beds were occupied by no pregnant patients with COVID, in our maternity, only 5–10% were COVID cases. So the question rises, can we create a virtual barrier to ensure that pregnant women and their babies receive the safest care? Well, we can try to do this, but the cons is that it can collide with the principle of equity and a sense of solidarity towards other more seriously affected patients who need beds, who need also our human resources. So we try to create some protocols to create clear zones, and where these protocols were quickly violated because patients were embarrassed sometimes to tell their symptoms at triads, because sometimes asymptomatic cases were not detected because some signs, fever, for example, intrapartum fever, was difficult to interpret. So we saw that it was very, very difficult. And at the midpoint, although we assume that we have to give up many of our spaces and do early discharge for the mothers, share rooms, limited the visits, all this, we know that we have to do so. On the other hand, our chiefs, our directors understood that due to the special characteristics of the population that we serve, it's more than desirable to carry out an universal screening. Because we know that a patient that is going to be admitted at hospital has asymptomatic SARS-CoV-2, maybe we can do a correct bed allocation of this mother. We can do a safe neonatal care. We have the opportunity to detect and schedule the follow-up. We don't know many things about the short-term or long-term development of these babies. We have to detect them, to provide them an appropriate follow-up. And it's also important for the protections of families and healthcare professionals. You can see here in this study of Sutton published in the New England that when they did in New York the universal testing, the peak of the pandemic, they could find that 13% of tested women were positive but asymptomatic. On the other side, some concerns regarding if other mild affected patients who are not being tested, maybe it's not justice, or if, another question is that PCRs that are only available in high resource hospitals with efficient labs, if we can do it. But if we think that we can, we feel that it was important to implement a universal testing for all women admitted at our maternities. So the next question is which test we have to use, and we have these tests that are tests that identify antigens, but I strongly not recommend them because for the lack of validation and low sensitivity, so forget about them. They are not good tools nowadays for diagnosis. And then we have the gold standard. The gold standard is it is what we have used for our universal screening, is the PCR, polymerase chain reaction assay, for detecting current infection. Its diagnostic accuracy depends on several factors: the type of assay, the site of collection, the correct technique for collection, but the main factor is the presence, of course, of a viral genome in sufficient amount that we can use it to be amplified by the PCR. So in general terms, we can say that maximum sensitivity for PCR in asymptomatic or mild symptomatic patients that they are most of our pregnant women is when symptoms starts, maybe after in days 1 to 3 of illness, decreasing to 80% after 1 week, and decreasing to less than 50% after 2 weeks. So in symptomatic patients, the window to diagnose is narrow. And it may be expected, as Sutton already discusses in his brief article, that a symptomatic screening method may be highly effective in the peak of the pandemic, but not so much as the time goes by. And then we have another possibility that we have this serological ELISA test to detect the SARS-CoV-2 antibodies. Contrary to what is believed, these tests can be used for acute diagnosis because especially antibodies, IgMs are produced quite rapidly after infection. And even after only 3 or 4 days after the first symptoms, we can detect in some patients antibodies. And after 1 week, most of them we can detect these antibodies. Therefore, they can be used at adjuvant tool when we can use them. It will be important to use them. Also, not only to study the seroprevalence, but also to detect some active cases when PCRs start to be negative. Sometimes can be rescued by the detection of IgMs in ELISA assays. It is important that the enzyme, the ELISA is directed to antibodies against the spike protein and not to the nucleocapsid, since the spike protein is specific for the new coronavirus, but is not the same for the antigens of the nucleocapsid that can present cross-reactivity with other human coronaviruses. So with these tools, as I said, we use the PCRs, and here you can see our results. As you can see, most of our COVID-19 cases in pregnant women admitted to delivery were diagnosed in symptomatic cases around the peak of the pandemic. Remember, here at the middle or the end of March. And as a result of suffering some cases that were not diagnosed until the postpartum, then here, 31st of March, we decided to perform PCRs on all pregnant women with a programmed delivery or induction delivery or a cesarean section. And in this period, from the 31st of March to the 8th of April, when we started the universal screening, we tested 17 patients, 17 women, and 3 of them were positive. So it was a 17%, that is more or less the same that was reported in New York. But from the 8th of April onwards, we have only detected 1 additional case. So this is the time where we only diagnosed symptomatic cases, and this is the time when the peak of the pandemic was. And then when we initiate the universal screening, our cure was decreasing rapidly. So this is how our data compared to the ones of New York, while universal screening started in New York just immediately after the lockdown and during the ascent period. We did it 23 days later, so already in a stage of rapid decline, the cure. So this justifies that the detection rate for asymptomatic women admitted for delivery was much higher in New York, 30%, that was in our setting, that was only 0.5%. So universal screening, in my opinion, in our opinion, have several advantages. It permits the identification of asymptomatic women admitted to delivery. We are admitting many asymptomatic patients in our unit, so we need to do something for a correct allocation, for newborn monitoring, and also for protection of mothers, babies, families, other patients, and healthcare givers. We have limitations with PCRs, as you can see. The effectiveness highly depends on the circulation of new cases in the community. And maybe in the near future, if we can develop these serologic tests that now they are being developed by our labs, the addition of blood serologic tests to detect IgGs and mainly IgMs antibody to the SARS-CoV-2. With them, we will be able to identify some patients with current infection, with of late presentation, and we will know the seroprevalence in pregnant women. And that's all. Thank you very much.
Excellent, Ignacio. Let me ask you once again, Ignacio, what is the main reason to do universal screening in pregnancy? Once again.
For us, it's very important that the protection. For us, it's very important that all the people involved in pregnancy care, neonatal care, could be protected. For example, one of our first cases of COVID, when we did not perform the universal screening.
Sorry, Ignacio, this is the protection of healthcare. As a first point.
One of the reasons is because, for example, her husband went to the neonatal unit, and 1 week later, half of the staff of the neonatal unit were ill. So it was really a problem. Also for transmission and for the security of all the staff or anesthesiologists. Many of them were very, very afraid of doing their procedures if they didn't know the results of the PCR. So we solved all these problems with universal screening. It is
actually carry on, yes.
No, this is one of the short-term most important, one of the reasons, of course, to protect the mother, but also the professionals.
Yeah, Ignacio, we had many questions about that topic, and then we will discuss it after this session. I think it's better to move to Gabriele Saccona, and he's going to talk about quite new topic, the lung ultrasound for early diagnosis in COVID-19. Gabriele, please welcome.
Hi, chat. Can you hear me? Can you see the slide?
Yes, I do hear you, but now you have to share your slides now.
Okay.
Again. Excellent.
Okay, it's working now? Okay. Thank you, chat. Dear members of WAPM, it's a really honor for me to have this lecture on lung ultrasound for early diagnosis of COVID-19 in pregnant women. I would like to acknowledge my colleague, Rosanna Esposito, who is doing a great work on lung ultrasound, both in research field and clinical setting, and helped me in this presentation. And my other colleague, Chris Bianco, who helped me in this lecture. So far, in this great meeting, we talk about COVID-19 in pregnant women. So, okay. Pregnant women are a special population who require attention to prevention, diagnosis, management. We talked about therapy. And we all know that diagnosis of COVID-19, according to the WHO, is based on the real-time PCR, and therefore on the detection of the virus on the oral swab. There are two main issues with the swab, with the real-time PCR. The first is the high rate of false negative, about 30–35%. That's why we need to resample women if there is an high suspicion. The other problem is that according to different clinical settings, it may take time. For example, in our hospital, it takes also up to 24 hours. That's why sometimes we can diagnose COVID-19 even with the negative swab, but a positive, for example, CT scan. COVID-19 is indeed a respiratory infection, and therefore lung examination is a required part of a patient clinical evaluation with the CT scan. But pregnant women, however, we need to avoid exposure to radiation. That's why a radiation-free point-of-care diagnostic tool, such as a lung ultrasound examination, would be particularly useful for assessing the lung of pregnant women. And we as obstetricians are a category, of course, that we use ultrasound in our everyday clinical practice. However, as you can see, we made the systematic review, and there are very few papers on the lung ultrasound in pregnancy. Basically just one case report and very few cohort study. And data are basically on women with preeclampsia and with the pulmonary edema. Indeed, the ultrasound is a very good tool for all disease of the lung with water, such as pulmonary edema. Data on COVID-19 are basically on non-pregnant patient that show that lung ultrasound has a very good specificity and sensibility, even if lower compared to CT scan. Regarding lung ultrasound examination in pregnant women with suspected COVID-19 infection, there is a very good paper from the group of Rome, of Professor Testa and Professor Scambia, where my colleague Rosanna Di Sarno is working with, and they are hardly working on lung ultrasound in COVID-19. They recently published a very nice case report in a pregnant woman, recently published on the American Journal. This is a very useful guideline published in the Ultrasound Journal on how to perform a lung ultrasound in pregnant women. They made a very important statement. The first of all, that we are a category of clinicians that we use ultrasound in our everyday practice, so we are comfortable with this tool. And that this is the most important one from a technical point of view, and I will show you later on, examination of the lung soon after obstetric ultrasound evaluation is very easy to do for all obstetricians. If we just need to distinguish between abnormal and normality. And of course, this is a quick technique, easy to learn, and with a good sensibility and specificity. That's why it's very good for emergency situations such as the COVID-19 epidemic. But how does it work? So we know from the physical basic of a lung ultrasound that, of course, the ultrasound beam traverses, the hair, so we can easily see the pleura. The pleura is this hyperechoic line, indicated by the arrow. And so we can see also behind this line, other horizontal line parallel to the pleural line. This is basically hyperechoic artifacts that's called the E line. This is the ribs, this is the E line. So in normal lungs, we can see the hyperechoic line, so pleural line, the ribs, and the E line, horizontal line. Of course, since ultrasound does not penetrate air, of course, we cannot see the pathology that is not contact with the pleura. For example, we cannot see a deep cancer nodule. That's why this technique is not appropriate for cancer screening. While it's a very good tool for diseases such as respiratory distress syndrome, pulmonary edema, pneumonia, where lung is still aerated, but there is a variable amount of waters that alter the, these windows, these acoustic windows. So we lost the horizontal line and we see this vertical line. This vertical line is called the B line. So before we saw the E line, horizontal line, normal lungs. In this case, we don't see anymore the horizontal line, we see just few B line, this vertical line. In inflammatory lung disease, such as, for example, bilateral pneumonia, including early stage COVID-19 pneumonia, we have losing of the horizontal line, and the vertical line is more confluent. So the pleural line is irregular, is thickened, and this is a suspicious of early stage COVID-19. This is another important pattern. It's called the white lung. So in this case, all the lung parenchyma is increased, but not extended in a controlled state. For example, this is a condition of distress syndrome, including COVID-19 related distress syndrome. So we have an ultrasound examination with the white area, and we call it this pattern white lung. So no horizontal line, no separate vertical line. In case of bilateral pneumonia, in case of atelectacy, the lung is almost completely collapsed. So in this circumstance, the involved area of the lung loses its air and becomes like a solid organ that can be evaluated by ultrasound as any other organ. For example, when we do ultrasound of the liver, this consolidation appears as an irregular hyperechoic area. We can measure, like with the caliper, and see also how is big this consolidation. So we see, we talk about the pattern of the lung. So now just a few practical points about machine, probe, and setting of our ultrasound machine. So basically, lung ultrasound can be really performed with any type of machine. We can use a linear probe, convex probe, microconvex probe. Based on the literature, the linear probes is the better one for examination of the lung. Of course, we as obstetrician mostly use convex probe, which is a good probe. There is no lung specific setting. We need just to adjust focus, zoom. It's important to reduce the gain because we need to highlight the hyperechoic pattern, so of the white line, E-line or B-line. Patient position is basically the same of the ultrasound examination. So supine position, there is different landmarks. There is 14 landmarks. It's important that after examination of the fetus, of the uterus, we just go up in the chest and we do examination of all the lung. Of course, to cover the whole chest area, we need to put our patient in sitting position, also to examine the lateral lungs and the posterior lungs. So this is just bullet points and practical points. Ultrasound examination can be performed at patient bedside. Position, normal supine position, prone position, left position, right position. So the important is to cover all the chest area. Of course, if we are doing our ultrasound examination because of COVID-19 infection, we need to take care about disinfection, use appropriate equipment, of course, disinfection, the machine, and the probe before and after examination. We need to be comfortable and familiar with all the pattern, so the pleural line, E-line, B-line, and the pattern of the disease, so the white lung and the consolidation. I suggest you to read careful the guideline published by the group of Scambia. There is the link on the bottom of this slide. And there is also a nice video clip that you can see with the nice tips and tricks of these technical tools. So basically, take-home message are that the ultrasound examination of the chest of the lung can be performed in every pregnant woman at a patient bedside. Obstetrician can perform lung ultrasound after routine OBGYN examination. Of course, the use of ultrasound avoid the use of radiation compared to CT scan. The pathologic ultrasound pattern, including the pathology pattern of COVID-19, can be easily identified by obstetrician. I would like to share with you some picture of a normal and abnormal chest ultrasound examination. So we have a figure 1. In the figure 1, we have a regular picture with the normal regular pleural line and the regular figure 2. We have a sporadic B-line that can be suspicious of COVID-19 infection, mostly bilateral. Figure 3, we have irregular pleural line, which is thickened. We have no more E-line, we have multiple B-line. It's a very indicative of COVID-19 infection. If we see the white lung pattern, as in this figure, in this case, there is a high suspicion of several viral pneumonia. In case of more severe viral pneumonia, we have this consolidation. And in case of consolidation bigger than 1 centimeter, of course, the severity of pneumonia is much bigger. So I hope this may help you in assessing suspected women with the COVID-19. And just to talk about my institution, we are using this tool in the labor and delivery triage, and we are trying to introduce as a universal screening because we are not comfortable with the rapid test, with the rapid antibody test, and our swab, as I told you before, take long times, take up to 24 hours. We are also collecting data about this tool and about our patient. And of course, we hope to publish this soon. Thank you very much.
Great, Gabriele. Thank you very much. That was very interesting presentation and new topics in obstetrics and then new ultrasound tool. I am sure that we will get more questions and comments at the end of session. Let me introduce Professor Oluş Api. She's going to talk about the course of COVID-19 disease in pregnancy, and then we're going to discuss another part of topics. Please carry on, Oluş. Welcome.
Hi. I will go through the course of COVID-19 in the pregnancy. But before that, we should go through the course of the disease in the non-pregnant population. The large cohort from China has reported that 80% of the patients go through mild to moderate infection. And only in 14% they have the severe infection, and the rest 5% has the critical symptoms related to the coronavirus infection. The overall case fatality rate is 2.3 and sometimes reported to be between 2 to 4% in the non-pregnant population. And the case fatality rate is, of course, higher in the patients with this critical disease, reaching up to around 50%. And when we look at the maternal effects of pneumonia in pregnancy, as we know from the previous causes, it's an important cause of morbidity and mortality in the pregnant patients. And viral pneumonias are known to be associated with higher morbidity and mortality than the bacterial pneumonias. And to give an overall figure, around 25% of the cases with pneumonia in pregnancy will need some type of intensive care unit treatment or will need mechanical ventilation. This is the figures coming from the previous viral pneumonia, especially viral pneumonia cases in pregnancy. Just to have a brief idea, we can look at the case fatality rates at the previous pandemics. For example, for influenza, which covers the rate of the Spanish flu going to the swine flu, the case fatality rate is changing between 8 to 27%. And this is 0.1 to 1% in the non-pregnant population. For SARS, the case fatality rate was around 25% among the pregnant population, which was 10% in the non-pregnant population. And for MERS, the case fatality rate among the pregnant was again increased when compared to the non-pregnant population. So this was what we were really fearful about when the COVID-19 had the outbreak. We just were very worried about our pregnant patients, the pregnant women and their neonates, of course. But the literature data from end of December to the beginning of April, which contained around 154 pregnant women and 118 live-born neonates, did not show such an increased risk of maternal mortality and morbidity. This finding was really, really very interesting. Just to give a figure from New York, the disease severity, just like the previous pandemics, just to compare, you can see 86% was mild cases from the New York data, from the 43 cases presented from the New York 2 affiliated centers. The 86% of the pregnant women had the COVID-19 disease in the mild form, and remember the 81% in the non-pregnant population. It was 9.3% severe disease, which is 14% in the non-pregnant population from the Chinese cohort, and around 5% had the disease in the critical form, and this is almost the same rate in the non-pregnant population. But in this study from New York, it's important to note that the mean maternal age was around 30. The women admitted to the hospital due to COVID-19 diagnosis were rather young women. An interesting paper has come towards the end of April this year from Iran. And this paper was a little bit different when compared to the previous reports, because this report was the report of total of 9 pregnant women who have experienced severe cardiopulmonary morbidity or mortality following to admission to any one of the 7 maternity level 3 maternity hospitals in Iran over a 30-day period of time. And these cases were not selected by any form of systematic surveillance, but they rather arose through a voluntary reporting of maternal cases. And the severe cardiopulmonary disease was defined as need for ventilator support and or cardiopulmonary collapse. These reported 9 pregnant women, 7 of them died and 2 survived, and the 2 survivors were still alive at the time of reporting. The time of the reporting in this paper was on the 20th of April. The maternal characteristics in this study was a little bit different when compared to the New York data. In this series, the mean maternal age was 36. The women were older than the New York series. And in this series, 5 out of 9 were 35 years of age or older. And 2 of these 5 who were over 40 years of age. And the 2 surviving women both were 35 years or older. And in this cohort, or in this retrospective 9 cases, no patient had pre-existing comorbidities, and all the women on admission were normotensive, excluding the diagnosis of pre-eclampsia. In this case series, the authors compared the outcome of the patients with their families or with their household people who were exposed to these women who were infected with the coronavirus. And these 7 cases who were dead, when compared with their exposed family members, none of the exposed family members were dead. As you see in this figure, son, mother, advanced age father, husband, they were all involved who were exposed to the coronavirus. They all recovered, but all these 7 women were dead due to the COVID-19 infection. But the take home from this message is not that the maternal mortality or morbidity is increased in women, but this is in contrast to the prior reports suggesting the mortality among pregnant women by the SARS coronavirus 2 is not increased. As Professor Kuryak, as in the opening speech, has highlighted the importance of the scientific data and the evaluation of the evidence from the scientific papers, we should take into account all the cases from the world. And this paper is important in demonstrating that the fatal maternal cases are not 0. So maybe this paper should prompt re-examination of any current guidelines. Maybe we have some unproven reassurance of the absence of death among pregnant women with COVID-19 disease. On the other hand, pneumonia in pregnancy has some perinatal effects. Previous papers have suggested increased risk of premature rupture of membranes, preterm labor, fetal death, intrauterine growth restriction, or neonatal death in women with pneumonia. And again, when we go through the papers related to the previous pandemics and the pregnancy outcomes, we can see both the influenza, SARS, and MERS have caused some important increased risks of perinatal problems. So again, with the outbreak of the COVID-19, this was expected from COVID-19 infected mothers. And for influenza, SARS, and MERS, no vertical transmission could be demonstrated. Just a brief words, some brief information for the vertical transmission of SARS coronavirus 2 or the novel coronavirus. We are not very much convinced that the vertical transmission does not take place. Yes, most studies have shown no detectable viral DNA in the amniotic fluid, serum, placenta, breast milk, or vaginal fluid, but there are some studies, 1 or 2 case reports, which have found some immunoglobulin M in the neonatal serum. And especially these IgM reporting papers, one of them, the blood was collected just 2 hours after the birth of the neonate. And the neonate was not in contact with the mother. The mother was delivered through cesarean section with endoxam N95 mask. And the 2 hours later of the delivery of the infant, some blood was collected and IgM was detected in the serum of the baby. And as you know, IgM does not cross the placenta, but also it usually does not appear until 3 to 7 days after infection. So there are some very few sporadic reports which suggest that in utero infection may have occurred. So that's why until some more information is gathered, we cannot convincingly or reassuringly say that there is no vertical transmission. Yes, most of the papers do not show vertical transmission, but we need more data to be more reassuring about this vertical transmission issue. And when we go through the perinatal effects, the effects of the first and second trimester exposure, in fact, are not very well known because most case series of pregnant women with COVID-19 usually report the outcomes of pregnancies in the third trimester. For example, when we look at the most recent systematic review, which includes 6 papers and 6 good quality papers and 51 patients, we can see that 49% of these 51 cases were the cases in the third trimester. There was only 2 cases from the second trimester and no cases during the first trimester. So we do not actually know what happens if the mother is exposed to COVID-19 during the first or second trimester. We have more data for the third trimester. We are actually worried about the effects of this virus on the placenta because some study, only one study actually, in the SARS coronavirus, the previous SARS coronavirus, has shown extensive fetal thrombotic vasculopathy in the placenta. And the high percentage of the fetal growth restriction in the 2002-2003 SARS outbreak maybe was due to this placental effect of the coronavirus. And there is now one paper from China which shows 3 cases of placenta from the mothers who had COVID-19 infection in their first and second trimesters of pregnancy. And this paper showed increased amount of fibrin deposition and one case hemorrhagic, one case massive placental infarction. So we are worried that the first or second trimester exposure to the COVID-19 may have some detrimental thrombotic effects in the placenta. So this possibility should not be overlooked during the follow-up of women who were infected in their early first and early second trimesters. And maybe this study group established by the WAPM may give an answer to this because we are, I think, approaching 300 patients, around 300 patients. So we need more and more data, especially from the first and second trimesters of the pregnancy. As I said before, the third trimester exposure effects are well known because most case series are reporting these pregnancies, the pregnancies in the third trimester. But the major problem with the third trimester exposure, as has been emphasized by Professor Kuryak, is that they are being delivered pretermly. And most of the cases, they are delivered pretermly on an elective basis due to the overprotection of the mother or the neonate, not based on proper obstetrical indications. Whether this approach is warranted or not really remains to be established. This is an important concern for the pregnancies in their third trimesters, just a dilemma for the patients and also for the obstetricians. Just look at this review of this 6 studies, the 51 patients. You can see the indications to cesarean sections in these cases. More than 50% of the cases are delivered by cesarean section just with the indication of COVID-19 pneumonia. No obstetric indications. 26% you see PROM, 17% fetal distress, 11% due to preterm labor, 8% due to previous cesarean, 5% or 6% due to pregnancy, previous stillbirth, and only 5 to 9% for pregnancy at term. So this is a very important issue which should be discussed for the management of patients in their third trimesters with the COVID-19 disease. When we look at the fetal and neonatal morbidity and mortality, again, these papers from the end of the December to the beginning of the April, which includes 154 pregnant women, did not show increased fetal, neonatal morbidity and mortality. And some small papers have not shown any increased rate for the missed spontaneous abortions or spontaneous preterm births. Some small increase in PPROM cases. And up to now, with this 154 pregnant women, there have been 1 stillbirth reported and 2 neonatal deaths reported. And it's important to note that this 1 stillbirth and the 2 neonatal deaths were reported in critically ill pregnant women. Again, when we come to this interesting paper from Iran, we can go through the details of these 9 pregnant women who were critically ill. 7 of them died and 2 survived. The perinatal outcome in the maternal loss group, as you see, in these 7 patients, 3 of the babies died in utero, and 2 of the babies died after birth. So the total of the 5 babies were lost in the 7 dying women in this study from, or the case series from Iran. The perinatal outcome is really very not good in the women in the intensive care unit or who died. When we look at the 2 cases who survived, the perinatal outcome in the maternal survivor group, we see that 1 of the babies died in utero. Here you can see the case 9 at 36 weeks, the baby died. The other baby who were delivered 34 weeks, there was no fetal death. So the perinatal outcome seems to be better in the other one. In the one of the babies was dying in the maternal survivor group, but the other one has no neonatal death. So a total of 1/2 baby was lost. It was 50%. So this paper shows a little bit maybe increased concern for the fetal or the neonatal health situation of the babies in mothers with COVID-19. So my last 2 slides will be on the symptoms, but this was covered by Ignacio previously, so I will not go in the details, but the symptoms in the non-pregnant and the pregnant women seem to be very, very similar. They mostly present with fever and dry cough, as you know, you can see in this paper, and this asymptomatic infection rate is very, very important. We don't know the actual prevalence in the non-pregnant population, but we know some papers, as has been shown by Ignacio, that women in the pregnant women can have the infection asymptomatically. So especially in geographical areas with high prevalence, asymptomatic infections should be searched for. And to keep up with time, I will not go into the details because this was shown by Ignacio, but don't forget that pregnant women may be asymptomatic at admission, and also they might not have any symptoms during their hospitalization period. Okay, thank you very much for your attention.
Excellent, thank you very much, Oluş. That was a very nice part of the session. Then I'm sure you will have more questions about these topics, which are very hot. But you know, let me start my presentation, and after that we're going to have more discussion if you like it. Then here we go. This one. How do I manage this one? If somebody knows, maybe they can help me. It's a joke. All right, awesome. Yeah, it's getting boring, but just 10 minutes more. Thank you very much. All right, here we go. Yeah, this is the program what we are dealing with today. We decided to make a webinar on COVID-19. Of course, this is the very serious condition throughout the world. The name of WAPM is World Association of Perinatal Medicine. Therefore, this is one of the aim of the society. We have to take care of such kind of clinical topics. Just coming back on the number in the literature, here you see at the beginning we were in a very serious anxiety about the results of clinical condition for COVID-19 because of SARS and MERS had a very important and very worse clinical outcome. But we've seen later on the clinical picture is a little bit different than SARS and MERS in COVID-19. Here you can see this maternal mortality is very high in SARS and MERS. Then also mechanical ventilation rates were very high in SARS and MERS, not very much in COVID-19. Miscarriage and IUGR, and especially the preterm birth, very high in SARS and MERS. I will come back on that issue, preterm birth in COVID-19 cases. This is another issue we have to take care of. This is another study published by IAPM, just March 15, submitted. They looked at the number on the MERS and COVID-19, but as you can see, numbers are so small. This is one of the reasons why WAPM decided to make a registry on this topic. This is the large data came from Wuhan, China. They collected the pregnant data from 50 hospitals, from also 118 women. They looked at the numbers, and then what they found was the risk of severe disease in this pregnant population about 8%. Comparing to SARS and MERS, quite favorable. Then they commented that the present data do not suggest an increased risk of severe disease among pregnant women. This is another table. We can look at only this part. Here you see this part, and then look at this preterm birth rate. It's 21, 18, and 43. Then abortion is 8% and 8%. And then here you see the cesarean section and the obstetrical indication, and only due to concern about COVID-19 is 39, 61. But I suspect this 39, that I believe this is due to concern about COVID-19. In all patients. This is just recently published by Gabriele Saccone. If I miss something point, then Gabriele can make a comment on this paper. What they looked at SARS and MERS COVID cases and COVID-19 cases. Here you can see they looked at the literature. Here you see the cesarean delivery is 80%, preterm birth 80% in this study, the MERS COVID-19 30 and 40, but COVID-19 preterm birth 44%, then the almost all cases 100% cesarean delivery. But the numbers are so small. This is one of the reasons why we decided to make a registry. Then Giuseppe Rizzo and Gabriele Saccone helped me very much on that study. This is another, the point, which is the fetal side. Here you can see this has been published by Maziya Zamania from Iran. They looked at the amniotic fluid and they found that the positive PCR tests in amniotic fluid, and then they concluded that this is the fetal infection, but they were, I'm not sure whether they collected amniotic fluid properly, but could be fetal infection or at the time of delivery. This is another study published by Turin Group. Here you see this one is a mother and this one is a newborn. The rectal and stool swabs were positive. The post-delivery is negative and placental swab negative. And in newborn, in that patients, nasopharyngeal swab after birth in ICU admission, the first sample is positive, then second sample is negative. But what they concluded that the virus has been found in stool, therefore there is a potential transmission of the COVID-19 viruses at the time of delivery to newborn. This is another study. Why I put the slides, you see, the publication in the literature, the few numbers has been published. Then what they looked at, the specimen tested amniotic fluid, cord blood, neonatal throat swab, and nasopharyngeal swab, and then they looked at and they couldn't find any positive test which is showing, which could be the fetal infection or intrauterine infection. Here you see this one, just recently published, from 5 publication, but they couldn't find any positive tests in amniotic fluid, umbilical cord blood, placenta, whatsoever. Then this publication has come out just recently. Here you can see the recently published. What they found, they looked at the placenta, they made a section of the placenta, not just the placenta, the maternal side, that also the need to cord insertion, and then they found the COVID-19 positive in this specimen. They looked at the electron microscope study. They said this is the first case of placental infection. Yes, this is the first case of placentation. The COVID-19 could be affecting the placental function and morphology or function, but until now, then maybe there is, but I couldn't find any fetal infection proof in literature. Here you see this they published this one just April 30. What they looked in the maternal side is a SARS-CoV-2 is a positive, is a PCR test. The nasopharyngeal control positive, but vagina and blood is negative. Umbilical cord is negative. Amniotic fluid is negative. The fetal mouth the negative. But what they found, the placental submembrane was positive for COVID-19. But these are few cases in the literature. This is the reason why we decided to make this study. Here you can see the contribution from different centers, the different friends. And then I have to admit that Gabriele Saxone, I made a lot of effort to make this paper come out, and it's been submitted to journal. Here you can see this is the country. I think it's more than 20 countries represented, and then 75 centers throughout the world. You see the centers, which is contributed very much to study. Despite the large and rapidly growing number of cases worldwide, still limited data are available for COVID-19 in pregnancy. Let's see, what is our results. But we looked at, as a first part of study, the clinical characteristics and clinical outcome in our series. There will be the second part and third part of the study. This is still ongoing study. We are having every day new cases in the registry. What is the value of the study? Largest cohort, COVID-19 infection during pregnancy, published. We had 388 pregnant women. Yes, 72 different centers and 22 countries, Europe, Asia, America, and Oceania. What they found, and I will look at the table later on, the high rate of preterm birth, perinatal mortality. It's about 2% neonatal that mortality. The risk of vertical transmissions was negligible. We had only one case in our group. And then what is the implication of this study? In the present cohort, mortality rate was low. The suspected vertical transmission, one case. And then unfortunately, amniotic fluid was not tested, and specimens from the placenta were not obtained in this first part of the study. This is the flow chart of study. I will not go through this. Then if someone wonders, then after publication, they will look at. But what is the important message from this slide, our table? Here you can see the infection in first trimester is about 8%, and second trimester 22%, third trimester is almost 70%. This is the distribution of the cases in our group. But what is the important thing for me? We will be following this first trimester, second trimester pregnant cases which are ongoing pregnancy now, and then we will let you know the results after delivery. Here you see the 123 at the time of closing this paper, ongoing pregnancy. First trimester abortion is 19.4%, and then stillbirth is 2.7%, neonatal death 2%, and the perinatal death is 4.2%. Just bear in mind that most of the cases were in the third trimester completed cases. The preterm rate is about 26%, is a little bit high. The possible vertical transmission is about 0.4% in our group. This is the numbers we can discuss at the moment. And then this is ongoing study. I'm going to stop here. And then there will be the second part of study. If someone has COVID-19 positive pregnant case, then they will enter their data. They will be joining the study, and then we will let you know the results of ongoing pregnancy. This is the most important part of study, and I have today. Thank you very much for your nice contribution, attention to all of them. Now is the time to have question and answers. I have to say there are some questions, but before that, I want to give the word to Jun Yoshimatsu, or we couldn't get any case from Japan. As far as I know, few cases in Japan, but we can get the latest news from June.
Yep.
Yeah, June, carry on.
Okay. I'm now living in Osaka City, the second biggest city in Japan. And the population here is about 8.8 million people living in Osaka. And the coronavirus, positive is now 1,713. And only 2 pregnant women were registered so far. And both of them are not so severe. I can say almost asymptomatic. So we don't have severe cases in Osaka. And in Japan, also the total infected patients are 15,600, and not so many now. And it's decreasing. And the dead people are only 600. So I don't know why there are so many differences between other countries, but I believe the first wave already peaked out, and we are waiting, preparing for the second wave.
All right, Jun. Good to know. Thank you very much for your contribution. And then I'd like to go to Dennis Lapa from Sao Paulo, Brazil. Our situation is getting somewhat tricky in Brazil. Maybe Dennis or Marcelo would like to say something if they are ready. I can see that they are muted. Okay, they are not ready yet. Oh, yeah, Rita, yeah, do you want to say anything about what is the situation in Brazil, or at least Sao Paulo? Go. We do hear you now. Carry on.
I can hear. Can you hear
Yes.
me?
Yes, I do. I do.
Thank you for the invite. This is a wonderful webinar. Here in Brazil, we are at the peak of the cases, but in pregnancy, we have almost the same comportment than in other countries. I don't know of all country, the numbers of our country, but we have a program from Albert Einstein Jewish Hospital taking care of 120 hospitals. And in these hospitals, we have only 2 deaths of mothers by COVID, but they had another morbidities. They had cardiopathy and other issues.
Yeah, very good.
We are doing the universal screen in our hospital. Our home care system triplicated their work. They are going to the home of pregnancies, the pregnancy's home.
Very good.
3 or 4 days before the birth to do the test.
Rita, thank you very much. We wish you all the best, and thanks also for your nice contribution. There is another interesting question. Maybe that question goes to Amos and Giuseppe Rizzo. Yeah, in the labor room, there is no any the negative pressure facility in the labor room. Then there is no any enough PPE equipments. But then they do have a COVID-19 positive cases on labor, and then also it seems to be the labor process will be long enough. In that case, what is your suggestion? Just carry on spontaneously, or it's better doing cesarean section? Giuseppe first, and then Amos next.
Theoretically, it's better to allow vaginal delivery, but looking to the number all around the world, I think most of the women underwent a cesarean section.
Excellent.
It's the reality.
Yes. Amos?
We don't do cesarean unless there are clinical indications.
Sorry, once again?
We do not do cesarean unless there are obstetric or medical indications.
But they don't have enough PPE equipment and no negative pressure room?
We don't, you should have, I mean, I don't know what to tell you. There's no indication as we see it right now to do cesarean just because somebody is infected.
All right, thank you very much. Another question is about sensitivity of PCR test in your country. That goes to Ignacio. Sensitivity and specificity of PCR tests in your settings, Ignacio.
Yes, it depends mostly if you have virus, still a high amount of virus in the place where you take the swab. It mostly occurs in the first days after the onset of symptoms. If the patient is has just started symptoms, sensitivity is about 90%. We only had 2 cases that we couldn't prove they were COVID cases by PCR. Then we have recently proved that they had an antibody, so probably 90%.
Very good. Good to know that. Is Gabriele around? Gabriele Saccone is around? Because there is a question that, and then is Gabriele around? How frequently do you find lung changes on ultrasound among pregnant women? What if they are symptomatic? Do you still expect lung changes? That comes from Zedi Abdullah Mehdi. Yes, Gabriela, go on.
Thank you.
Excellent.
Thank you for your question. So basically, we are starting to study ultrasound examination to all patients as universal screening, so both to asymptomatic and symptomatic. That's because our research regarding the rapid swab, regarding the rapid antibody test is limited. So basically all patients we are scheduled for inpatient admission are tested with the swab, while all patients in the labor and delivery triage and all patients with outpatient visit are scanning with the lung ultrasound. So if we have any suspicion based on the ultrasound chest, we asked for the swab, and we are doing quite well with this algorithm.
Very good, a good point. Thank you very much. And another question, somebody is asking many times, I have to acknowledge everyone, the record of this webinar will be ready on the World Association of Perinatal Medicine websites, and then by Tuesday. Therefore, don't worry about, because everyone is asking about to provide the presentation from all speakers, but all recorded webinar will be ready for participants a few days later. Don't worry about it. This is the service of WAPM, World Association of Perinatal Medicine, together with the Perinatal Medicine Foundation. Right. Another question I'm asking to Anna Teller to let me know what is the question from Spanish speaking participation. If I missed something, just let me know, Anna. In the English channel, please take this one. The Tanya Premru is asking about where pregnant women wait until the results of SARS-CoV-2 test is known. In Ljubljana, we organized 3 zones, white, gray, and red zone, tested pregnant women wait in the gray admission room, or in the gray delivery room, or in the gray room on a ward, depending on the indication for admission. Results are usually known in 3 to 6 hours. This is the contribution from Tanya. Thank you very much. That is very valuable. And then another question is, yeah, we answered this one, non-pregnant woman and the infection rate. That's fine. All right, this is another question to Olush, also to Nelly Jakova, and also Esin Koch. How to manage newborn baby from COVID's mother? Who wants to answer first? Maybe Nelly Jakova. Or Esin Koch, or Olush, who is ready first?
Do you hear me?
Yes, we do. Carry on.
So, first of all, we take all precautious measures when we enter in the delivery room, and after taking the baby, usually in an incubator, we transfer it in a special room where we take the swab, first of all, from the nasopharyngeal swab.
Yes.
And we do all investigations which we do usually for with a neonatal in the neonatal ward.
Very good.
So if the baby develops respiratory failure, respiratory distress syndrome, we follow the protocol for for treating the RDS, and all the staff which has to treat and take care of the baby should be on site with all precautionary measures.
Yes, very good.
Yeah, until we have evidence by PCR that this baby is COVID negative.
Good. All right, Nelly, thank you very much. That was very nice and excellent. And then the Gabriele is asking, to have the word. Yes, Gabriele Saccoino, do you want to say anything more? Any comment? If not, I will ask another thing. Would you like to comment on our study we submitted together, WAPM COVID-19 study?
Yeah, it has been a really great effort. Thank you to you, first of all. Thank you to Professor Rizzo. And I think that data basically show, as you told clearly before your presentation, that the maternal risk is quite low compared to non-pregnant women. It is quite strange compared to other virus infections, such as the classic flu or the coronavirus type 1. The mortality rate is low. The admission to intensive care is about 10%. And also the neonatal risk are quite low regarding vertical transmission. I think it's important to speculate about the risk of neonatal and perinatal mortality, which is quite high in our study. I don't know if it depends on the virus, it depends also on the high rate of preterm birth. Maybe for the secondary and third analysis, which would be nice to distinguish between spontaneous preterm birth and iatrogenic preterm birth, because I think that a lot of the vast majority of these preterm birth are iatrogenic. due to the fact that, you know, you have a woman.
Maybe unnecessarily, yeah?
Yeah, because you have a woman at 34, 32 weeks, it arrives at labor and delivery unit, you test positive to COVID-19, it's difficult to manage in a COVID unit, you are scared about infection of the personnel and providers, so you try to, you know, to be as rapid as possible. That's why there is also a high rate of C-section. So maybe the women arrive, you do C-section as soon as you can, so high rate of C-section, high rate of preterm birth, and that's why you can have also high rate of perinatal mortality. I don't know, it's a speculation, you know. I don't know your opinion about this.
Yes. Oh, thank you very much, Gabriele. Then there's one question to Frank. Frank, we do have the 3 COVID-19 pregnant. Let's say it's 20 weeks of gestation. You know, the family would like to know whether or not their baby had infection in utero. If it is, maybe they would like to have a termination pregnancy. Is that ethically, you know, the proper approach to make amniocentesis or something like this?
I would reassure them that to date, there is no proven infection in utero. And I would discourage them. Having said it, any woman can have an amniocentesis, so I wouldn't categorically refuse, but I would discourage her.
Thank you very much, Frank. That is nice. There is another anonymous question from the participants. Is there any correlation COVID with preeclampsia for the complications? We don't have enough data to make a comment on this, but I can tell you there is one case. It's about you know, fetal or intrauterine infection, but that case also preeclamptic cases is very early. It's around 20 weeks, and then because of COVID, they concluded in their paper. I urge you to go to that paper, but this is not very clear. Situation to be answered at the moment. Another thing, who is performing lung ultrasound and how many people are involved? What is the false positive rate of lung ultrasound screening, Gabriele?
So basically, we cannot do the diagnosis of COVID-19 just with ultrasound. So it's difficult to say the false positive and false negative rate. What we can do is to have a suspicion of a COVID-19 based on ultrasound examination, mostly on asymptomatic women. Of course, if I have asymptomatic women with the fever, I don't screen with the ultrasound scan. I prefer to do directly the PCR, of course. But as also we showed in our lecture, there is a high rate of asymptomatics. So we cannot do the swab to all the asymptomatic because of research, because of limited research that we have. So we can use the ultrasound as a first line screening, and then discern about people that deserve the swab and people that not deserve swab. So how many people are involved? Usually we scan just the doctor that is at the triage, or just a doctor that is in the clinic and that is doing the normal ultrasound examination of the fetus, just go up to the chest to do the ultrasound lung examination.
Gabriele, thank you very much. There is another question, but we answered this one. Just repeat again. It's about the anticoagulant therapy. Then, the doctors who is asking this question are referred to go to record webinar. Then you can follow later on. Before forgetting, I have to acknowledge that I'm very thankful to World Association of Perinatal Medicine board members and also the International Academy of Perinatal Medicine and the Perinatal Medicine Foundation supported this study, and this webinar happened. Also, thanks to all the speakers. There is one question for Amos. Do you use a CT scan? No, computerized CT, no. It's a tomography, yes. Do you use the tomography, CT, of a pregnant woman? How do you use it?
We don't, not as a screening tool. It's not a good enough screening.
Right. Does anyone?
When you have PCR testing and other testing available, the CT scan is not good enough to make the diagnosis. We also assume everybody is positive. So we use protective equipment for everyone.
Right. Another question, any recommendation drugs such as high dose of vitamin D or calcium to consume for a pregnant woman in antenatal visit? That was the question. Who likes to answer? I don't know.
Not recommended for the time being.
Okay. Do you recommend to continue the practice of a morphological scan and the first answer screening during the pandemic? Yes, we do recommend very much, but there are some options which you have to give to family. They can opt, but this anatomic scan is one of the crucial antenatal care. The patient shouldn't miss it. If anyone would like to comment on this, welcome. Ritza?
Are you talking about prenatal visits in general or just?
In first trimester scanning and the screening. Anatomical scan in first trimester and screening in first trimester.
One of the good things about the internet is that information is spread really, really, really quickly. So at the present time, both in England and in the United States, the societies are coming out with really good recommendations. I strongly recommend that you guys go to those recommendations on a regular basis and decide for yourself what the best recommendation is.
Right, thank you very much. Mario Campogrande informed me that there is a neonate confirmed vertical infection, and then I wonder the case publication for this. It's very nice. All right. Oh, I must say we had 1,900 registration for this webinar. This is the first webinar by WAPM. That is the good number. I think we had very productive. This was the first, our webinar. We've been a little bit late. Sorry about those things. Then if anyone would like to say as a last word, welcome. Otherwise, I'll be thanking to all of you, all speakers, all contributors, and all participants.
Thank you.
Yes, awesome. Please welcome.
Right. I truly enjoyed, and while I see many good news, I also see the bad news. First of all, total confusion regarding the true influence of corona on pregnant women, their unborn and newborn children. Because of this, scientific papers do not have the main scientific criteria to be published. First one, no control group, no long-term follow-up, and we all have to go with studies in the future. In the meantime, Jihad, I strongly suggest that all of our findings should be called observation, not recommendation.
Correct.
So
very good. Thank you.
Perform studies when we have more time, which do fulfill scientific criteria for scientific paper. Science must help. Science helped in many other things. Here we have something very paradoxical, and my friends Frank and Amos are just proper people to answer. Why corona affect strongly rich countries? For poor countries like Vietnam, like Latvia, like Croatia, have symptoms, have results which are very favorable. Shall we move to the public health protection? Shall we see how political leaders influence daily medical practice? And many of these problems are not to perinatologists. We have actually quite good reply from coronavirus. First of all, half of the world is affected. incidence of pregnant women is very negligible. Fetuses are almost not affected. No one newborn.
Yes,
is
you're right,
affected.
Asim.
So
yes,
those
right.
are fact of life. It seems that pregnancy, unborn babies, newborn babies are biologically protected, probably by immunobiology. This is the hot topic to study. Why? Why rich country have the horrible problem having the largest budget for new equipment, for good standard of their care and so on?
Yes.
I don't know.
Very good. Yeah. That is a good remark. Awesome. Thank you very much. The most of the participants are taking to all of you. One of them is telling that, thank you very much. Yeah, thank you very much for this interesting overview on this new challenge for all the women and their doctor all over the world. The other one is thank you very much to organizer and panelists. It's been a profoundly enlightening session. Looking forward to recording. I thank you very much. All. Also, I have to thank all contributors to register study of WAPM COVID-19 study. See you soon. I hope you will enjoy your time. Frank, yes, please.
Shahad, can I just
yes,
close with the sincere, and I speak for all 1,900 people, thank you to you. You brought us together. This is not an easy thing to you. Thank you, thank you, thank you.
Welcome, and then see you soon. Take care of yourself, please.
Thank
Best
you.
regards to you and to your family.
Thank
Bye.
you. Bye now. Bye.
Čuj.
Sihat.
Yes, just one announcement, additional announcement to translator. Please stop the record, your voice recorder, and then send it your file to me by email. And now let's keep in touch for the rest of the work we had to do for you. Thank you very much. All right, who is last? Who is last? This is a friendly club. Carry on. Yes, Rodrigo, do you want to add something more?
No, I think this was an excellent initiative, and I'm looking forward for the next one. I agree with Asim. It's a very symbolic numbers between rich countries and poor countries, and I hope here in Mexico we get better figures, better numbers, because we do need a full cooperation in order to get our system organized.
Very good.
And actually see what's going on.
Okay, thank you very much, Rita.
Thank you.
Is Dennis around? No, the Milan, our past president of WAPM from the neonatological part. Do you want to add anything more? Milan, welcome. All right. Thank you, thank you, thank you. All right then. Nelly, thank you. Thank you. Yes. Why?
Marcelo.
Hi, Marcelo. I cannot see you.
I can't see anyone. Are you hearing
right.
I congratulate.
No. You are allowed for everything. Okay, thank you, Marcelo. Take care of yourself.
She actually did a wonderful job.
All right, Marcelo. Thank you very much.
Yeah, it's over.
Now, Amos, this is the friendly discussion between us. This is the friend clubs now.
Okay, so can I speak?
Please, go
on.
on.
You did a wonderful job. I usually am not nice to people, so but I must tell you, you did a wonderful job. And
you did it.
You spent a lot of time getting ready for this. So I really appreciate this, and I'm voting that you can do this twice a day for the rest of the year.
Thank you. Sometimes we need compliments, but that compliment has to go to everyone.
But you did it well.
All right.
Yeah.
Aliyu, do you want to say anything, Aliyu, from Nigeria? Yeah, we cannot hear you, Aliyu. Labaran Aliyu, we cannot hear you, sorry. Okay, I have to say goodbye, everyone. Thank you, take care. Now, the evening in Istanbul, and then sunny day, sunny evening, all the best. Thank you.
We appreciate you.
Thank you very much.
Thank you.
Bye-bye.
Bye-bye.
Congratulations, Sihat.